All right, I'll get us started so as to use our time efficiently. Good afternoon, everyone. It is July 15th, 2025, and this is actually the first grand rounds of this academic year. So we're very excited to have you all joining. Some of you may be new. This is the Physical Medicine and Rehabilitation Grand Rounds for Johns Hopkins Medicine. Today we are excited to have presenting Dr. Jonathan Whiteson, originally from London, England, but has been at NYU, serving as a professor and at their School of Medicine, as well as attending physician at Rusk Rehabilitation, and also serves as vice chair for clinical affairs in their department. But he also serves in both the rehabilitation and medicine departments, and today he will be sharing with us PM&R, delivering value in the acute care setting. So I will pass the tile to him.
Well, hopefully you can hear me. And an honor really to be invited to speak with you all, and thank you so much. You all work in an incredible institution, a leading institution, it's really a pleasure. I gave grand rounds there a number of years ago. I was trying to remember what topic I gave it on, and forgive me, I don't remember, but that I've been invited back again either means that you guys forgot or you liked it. I'm going to take it that you liked it, and it's a real pleasure to be invited back. And I'm going to talk today about what we as PM&R physicians, PM&R clinicians, a PM&R department can offer in the acute care setting. And it's part of a talk that I gave actually at AAP. I was asked to give a similar talk to the chairs and administrators at AAP. I think it was enjoyed and appreciated. But I will also say that what I'm going to talk about, and our centers sort of reflect each other. We consider ourselves leading academic medical centers, and we are leading rehab departments. So there's a lot of similarity between what we do and what you do. And I think what's great about these conversations and discussing these topics is that this should not be a one-way street. This should be bidirectional, multidirectional, and this is the kind of information and discussion that we should be sharing amongst rehab departments, because when we are all doing what we consider to be the right thing in terms of how we practice, then we can really stand up for each other and support our field of PM&R. So again, thank you very much. I have no disclosures. My objectives, hopefully during this talk, you will be thinking about how PM&R can demonstrate value in a complex health system, anticipating opportunities to foster excellence in value-based clinical care. Consider within your department administrative strategies that can really facilitate value-based clinical care initiatives within your department and without, in other departments and through your health center. And prepare to discuss, not necessarily today, but hopefully we'll have some time for questions and discussion, but discussion going forwards amongst yourselves and amongst other departments you may reach out to. Prepare to discuss value-based care metrics that can be influenced by PM&R. When we talk about value-based care and we talk about caring for patients and we talk about cost, I thought this cartoon was crude and ugly, and I think that's sometimes what we think about when we think about finances, and we sort of can perhaps lose the purity of what medicine is all about, which is taking care of patients. But if we don't pay attention to value-based care, if we don't pay attention to value and to finances and to cost and expenditures, then we won't have a successful healthcare system. We won't have the best in outcomes. So we do have to pay attention. And we can often feel that there's the hemorrhage. There's a lot of money and a lot of disease, and we don't have the handle on this. And a lot of different elements that influence the way that we deliver care. And it can all feel a little bit out of reach and out of touch and out of control. But PM&R sees it in a different way. And PM&R, just from the character and personality within you and within me, we have what I consider to be a calming influence on the healthcare system and a very positive influence on the healthcare system. And some may see this as a setting sun, but I'm going to tell you this is the sun rising in the east. And a little tongue-in-cheek, but PM&R really does offer that opportunity of new growth, new birth, a new day, a way forwards. And this is a thought and a culture that we need to take forward. I'm sure many of you have seen this before. This comes from FAAPMR. We have great organizations, the AAP, FAAPMR, amongst others, that really do help bind us together and help us be the very best that we can do, but encourages us to work as a team and also to be bold, to step outside of our comfort zone, to take, I guess, a degree of risk, but understanding that there's great benefit, not just for PM&R, but for our patients and our health systems that we work in. So let's just think about PM&R value in the healthcare system. And this first slide is really about how we see ourselves. And as PM&R physicians or clinicians, we know what we do and we know how we help our patients. There's just no doubt. When you've had an interaction with your patient, you know that they're better off for it. They leave the office, they leave the hospital unit, they leave the clinic better than when they came in. There's no doubt we know this. And as PM&R departments, we fulfill our mission. We take care of patients, we fill our inpatient beds, however you want to consider what the role of a PM&R department is, we know we do that. And as a specialty as well, we know that we advocate for and are the experts who are best suited to help individuals with disabilities live their best lives. We know we do a great job. We live it and we experience it. But how are we perceived? What about other people in the healthcare system? And you've heard this, you've seen this. People don't know how to pronounce or don't know what a physiatrist is. They're called a psychiatrist or anything else under the sun. And then they say, well, what do you do? So as individuals, we're misunderstood. As departments, we can often be seen as being a roadblock. Who hasn't heard this? Why can't you just admit the patient right now? Why can't you take care of this, that, or the other on your inpatient rehab floor? There's little understanding from our hospital colleagues about what we do, what we can do, what we can't do, what our restrictions, limitations, and parameters are. And then as a specialty as well, in general, we're often overlooked, or perhaps patients are sent to the wrong clinician. And we just have not done a good job in marketing ourselves. And so our colleagues, systems, the industry just really doesn't understand exactly what we can do. And I will say that that's on us. That's something that we need to pay attention to. And that's what this talk is really going to focus on. And when we think about value, we have to talk about value-based care. And I'm sure you have heard of the triple or the quadruple aim of healthcare. And I'm going to repeat it here just so that we all understand. The first is about improved patient outcomes. Obviously, patients are very invested in this, and our health system is as well. Improved patient experience. That rating and ranking of the patients of the care that we give is really very important in terms of how we're perceived. Improved efficiency, which really means we need to do as good a job with less money, or perhaps even a better job with less money. So efficiency is really, really important, and the costs come into it a great deal. And then the quadruple part of this is the clinician's experience. Whether you're a physician or a therapist, an administrator in the department, we have to make sure that we have an improved experience as well. So that's a quadruple aim of healthcare under value-based care. And we know, but we have to demonstrate. We know that PM&R physicians and PM&R clinicians and this field, this business of PM&R departments are essential in value-based care. But how do we demonstrate this? What do we have to do to show that value and to allow people to really understand what we do and how we can make a difference, not just us knowing what we do? Well, let's try and understand who our key stakeholders are. And at the, I guess, the top of the food chain, so to speak, and obviously we all have to respond and understand what the language and the mission and the vision is of our C-suite, our executive leadership. We all have to be on a par and make sure that what we're doing in our department really does mirror the vision and mission of our executive leadership. We also have to make sure we're meeting the needs of our non-PM&R departmental chairs and specialist co-partners. It's very important that we help to take care of their patients and their challenges and issues as well. If we don't pay attention, if we don't understand what that is, then we're not going to make friends within the system. Our colleagues, other PM&R physicians and clinicians, we have to make sure that they are represented too and that they understand what we're doing and we understand what they're doing as well. Payers and insurance companies, obviously a dialogue with insurance companies and payers is important. Legislators on a city, state, and federal level, and various of our colleagues representing our associations do go to Days on the Hill to make sure that the legislators are representing our industry and our patients. Patients, obviously, are key stakeholders as well. They mean a lot to us. That's why we come to work and wake up every morning, and it's why we try to be the very best we can be. And of course, our researchers and educators who help us understand, overcome barriers and blocks, and help us teach the next generation of PM&R clinicians. So these are the key stakeholders, but we're only really going to have time today to focus on the C-suite and the executive leadership and really what language they're speaking and what they're focusing on. And this is really key, especially when it comes to value and value-based care. And we have to understand what is the executive leadership thinking when they're talking about value-based care. Well, this hopefully is going to resonate with you as it does with them. Value-based care is a healthcare model that focuses on providing the highest quality of care while minimizing the costs. That's the efficiency that comes into the equation of healthcare. We want best outpatient experiences, but healthcare has to be affordable. The key principles of achieving value-based care, obviously patient-centered care. We need to know what the patient's needs and preferences are and make sure that we're treating according to what their needs are. We have to make sure we do better today than we did yesterday, and tomorrow again better than we do today. We have to focus on the evidence-based practices and reducing those errors that we know occur. We have to learn from each and every one of them to hopefully eradicate them. We have to be budget sensitive. We have to be cost effective. We have to find and explore ways to deliver ever improving and complex care, but reducing the costs as we go along. And the crux and what drives all of this is data-driven decision making. Again, that bridges the gap between what we think we do and what we know we do. It turns feeling into fact. Data is absolutely key. And I know you're tracking data and we're tracking data, and we must make sure everyone in our industry is tracking data. Not that we treat to the data, but we treat within an environment that's created by past data. It really does help us identify those areas for improvement and measure the outcomes, and helps us to modify the care going forwards. But data, data, data. So let's just talk briefly about NYU. As I said, NYU and Johns Hopkins, you could mirror them. Baltimore and New York, not too dissimilar. We are a large academic health system. There's 7 hospital campuses, over 300 ambulatory facilities, 2 medical schools. A very healthy budget, a profitable health system, which in this day and age in healthcare finances and budget cuts, et cetera, is a challenge, but one that has obviously been at the center of our executive leadership's drive over the last 15 to 20 years. And in an environment in the Northeast, in New York, that is very challenging and other health systems are struggling and being supported by the state, NYU's managed to stand on its own 2 feet and has been profitable to date. and continues to grow in terms of profit. And that's in large part attributed to an increase in hospital discharges, an outpatient strategy, which has seen a significant rise in outpatient surgeries and procedures, and also an enhancement and an increase in size of our emergency room, which really feeds patients into our health system. So that's been the strategy of the NYU leadership. NYU is very fixed on metrics, and these metrics and this scorecard is updated on a sort of almost monthly basis. It gets sent out to all of us, and we all need to be aware of what our discharges are and our outpatient visits, etc. And our system is dynamic and forever expanding. But this is really key data. And of course, the rankings and the honors as well, also very key. And this one, which is the Vizient, in terms of medical quality and safety, NYU is very proud to be #1 in the nation when it comes to outcomes. So what about RUSC rehabilitation? Again, it's an academic department. We have 3 inpatient sites, 95 inpatient beds, approximately just over 2,000 discharges on an annual basis. In terms of our acute care setting and what we do, we have 3 consult services at 3 of our hospital campuses and an equivalent of 4 full-time equivalent physicians dedicated to the consult service. We are currently ranked #4 at US News and World Report rehab facilities, and #4 in Blue Ridge ranking, which is the NIH grant funding. And we're studied under a microscope in our environment. NYU executive leadership looks at every single department and its quality and its metrics and its outcomes, and we are driven. We are driven by our leadership to be the best that we can be. And that's the environment that we work in here at NYU, and what sort of drives us to think outside of the box and to create new systems. So let's drill down a little further and think about what demonstrates the value of PM&R to the C-suite. And I think a really important area, and one that I've been alluding to all the way through my talk so far, is hospital throughput. How do we think about patients moving through the hospital, their length of stay? But it's not just about getting patients in and out of our acute care setting. It's about the quality of care. It's about the cost of that care. And on the back end, it's about readmissions. And these are areas that we focus heavily on throughout our health system, every department, a global score, and then a departmental score for all of these metrics. And the executive leadership holds all of the departments responsible and accountable for what happens in the acute care setting. So as a department, PM&R is held in part responsible for the metrics that happen in the acute care setting. So as we look a little deeper and get under the microscope, what are the metrics that we need to think about when it comes to hospital throughput? Observed expected length of stay is probably the most significant metric, and the one that's certainly focused on most here in our acute care setting by our executive leadership. And I'm going to come back to ODE length of stay in a few moments. But hospital-acquired complications as well in a complex health system and with increasingly complex patients being admitted. How are we doing in the acute care setting, and what responsibilities do we have as a PM&R department to help reduce hospital-acquired complications in the acute care setting? Readmission rates. Patients leave the acute care setting and go home. Do we have a role and responsibility in helping reduce those readmission rates? They may come to our IRF sites, and if they stay a week or 2 and then they go home, if they get readmitted, that's a readmission for the acute care setting. And that's something that we need to pay attention to. And similarly, as I've been mentioning, is the budget. How do we become fiscally responsible and aware and make sure we're doing efficient care? So I'm going to provide you or show you just a little bit of the metrics from our acute care setting. And as I say, this is not that PM&R is responsible for this decline in hospital-acquired complications. We are part of a multitude of departments that are engaged in acute care, in the care in the acute setting. But hospital-acquired pressure injuries is related to mobility, falls and fractures related to mobility, infections can be related to mobility. So our engagement of our consulting physiatrists and our physical therapists and occupational therapists is key in this reduction that you see over the last 10 years, a significant reduction in hospital-acquired complications and a mortality rate, an observed to expected mortality rate that is one of the leading mortality rates in the nation. What about readmissions? As I said, we're all responsible, whether the patients go right home from the acute care setting or whether they go to RUSC and then home. And we've seen a decline over the past 10, 12 years in readmission rate. We're now under 3% in terms of overall readmission rate for our health system. And this is what the executive leadership are looking at in terms of the impact and the quality of care that all departments are contributing in the acute care setting. And again, the budget, as I've mentioned, is a healthy budget. So what about observed to expected length of stay? And then now I'm going to drill down a little bit on patients who are coming into the rehab department. But observed to expected length of stay is a really key metric. Really what you're looking at here is how long people are staying. That's the observed length of stay. And what is their expected length of stay based on their diagnosis and their comorbidities and their health status, their complexity. And this is a Vizient calculation. I do not have the formula. I'm not sure if anyone has the formula other than Vizient, how they calculate an expected length of stay. But it's a ratio, observed, how long they stayed, to expected, how long, based on their diagnosis and comorbidities, how long you would expect them to stay. And if you're hitting an O to E length of stay of 1, you're doing a good job. Your system is good. If your system has an observed expected length of stay greater than 1, that's an inefficient system. That means patients are staying longer in the acute care setting than they should based on their diagnosis and their comorbidities. If your observed to expected length of stay is less than 1, you're doing a stellar job, a really good job, a leading job, an efficient system. You're getting patients out in a shorter length of stay than is expected based on their medical diagnosis and comorbidities. So this is data that I'm showing you of patients who come to RUSC. They leave the acute care setting, they come to RUSC, and you can see from fiscal year 14 up to fiscal year 2020, we had an inefficient system. Executive leadership was not happy. Our departments were not happy. You know, our specialty departments were not happy when they saw this. And we all recognized, hey, patients are staying longer in the acute care setting when they should be coming over in a more efficient way. So we have to say to ourselves, where do we impact this efficiency? How do we work better getting patients from the acute care setting into the rehab setting? And I'm going to go over 4 or 5 topics that some are probably familiar to you, others may be new to you, but these were some of the tools we used and some of the programs that we implemented or developed. The first one we stole from you because you were the pioneers of early mobilization, and the whole country thanks you for the great work that you did at Johns Hopkins, looking at early mobilization programs. But back in 2015, 16, 17, we said, well, if Johns Hopkins can do it, we can do it too. Our experience was patients stayed a long time in the ICU and they stayed in bed and they functionally declined. And we recognized that all the teams in the acute care setting rounded individually. Patients were not managed well with regards to sleep-wake cycles, confusion and agitation. They were in pain when our therapists went by, when our physicians went by. They weren't in a fit state or they were asleep. And they weren't in a good way to do therapies. And the care culture was really about survival. No one was really thinking about life after the ICU. And executive leadership was not been engaged. No one was discussing with leadership what was going on in the ICU. So PM&R said, hey, Johns Hopkins have done it. We're going to do it too. Our PM&R team went into the ICU setting and said, look, let's collaborate as a team. The ICU team will run the medical care, but we'll all round together. And we'll address sleep-wake cycles and pain and sedation. And we'll think about what happens after the ICU. And we'll think about mobilizing our patients. And we will have our PM&R consulting physicians come and see your patients on a daily basis if needed. And therapy services, instead of 3 or 4 times a week for 20 minutes or half an hour, will be twice a week, 7 days a week for 30 minutes, and both PT and OT and speech as needed. And of course, to do this, we needed dollars, we needed therapists, we needed to reallocate. and we needed executive leadership buy-in. But this conversation happened, I'm sure as it did for you, and we had incredible results. Again, reflecting, I think, the results that you had in terms of reduction in ICU length of stay, reduction in med-surg length of stay, reduction in cost, increased discharges to home and home without services, obviously a reduction in need for post-acute care, and a significant cost savings. And we were happy and proud to publish this data back about 8-9 years ago. Just recently, 22 to 23, we repeated this pilot project on our transplant patients. We've had a transplant institute for the last 7 or 8 years now, and a growing number of patients are going through heart and lung transplants, as well as liver, kidneys, etc. And we did the same intensified care that we did in the normal med-surg ICUs with our transplant ICUs. And we saw similarly a reduction in admission to post-acute care, more patients went home, and a shorter length of stay in the acute care setting. So again, PM&R makes a difference. We're dose dependent. The more we're present, the more we're treating, the more we're engaged, the better the care is, the shorter the length of stay, fewer complications, etc. So what about patients who are leaving the acute care setting and coming over to our acute care, to our acute rehab facilities? And there's no doubt this is a complex process, which we're going to go through in a few moments. But obviously for us, it starts with the PM&R consult. And then we need to put in therapy orders, make sure the patients are getting treated. We need to make a decision when to admit the patient. We need the financial authorization. They need to meet criteria for an IRF setting. So let's focus on the PM&R consult and follow-up. And going back a number of years, we had a problem. We had patients staying in the acute care setting for a long period of time, and the acute care teams were calling us and saying, okay, we want our patient admitted today. They'd already been in the hospital 3 weeks or 2 weeks or a month. We want them admitted today. They're ready today. There was a limited understanding by our acute care partners of what our scope of practice was, what we could do in the acute care setting, what we could do in our IRF. We did not have a developed PM&R consult process. Every single one of our PM&R docs did consults. This was not just restricted to 1 or 2 doctors focusing on consults. This was every single physician doing consults. They would go very early in the morning, late in the day. They would be called by a tug on the elbow, a text, an email. Rarely was there any record of a consult being placed. We didn't have a time requirement, so there was a delayed consultation in terms of how long it took for the consults to be completed. It could take anywhere from a day to a week. And we weren't tracking any metrics. We didn't know what was going on. We didn't have any data. And this is what was happening in fiscal year 2020, which for us starts in September of 2019. But this was the year. We had about 3,500 consults that year. 53% were signed within 16 hours. That was the time that we gave our consulting physicians as we revamped our system. We said, you get your consults done within 16 hours, but only 53%, 54% were done in a timely manner. And the observed to expected length of stay, how long it was taking for those patients to come over, was very high, 1.42 in the fiscal year 2020. So we were a very inefficient system, and our acute care partners had every right to say, why are you blocking patients from coming over? We didn't know why. We didn't know what was going on, but clearly we were not efficient. So what was our solution? Number one, we had to go to our acute care partners and educate them about what we could do in the acute care setting and in the rehab setting. We set those timelines, 16 hours, get your consults done for all of our physicians. We said not every physiatrist is going to do a consult. We're going to limit it. As I said, told you before, we now have 4 dedicated full-time consulting physiatrists. We said this is a career path. This is not a dabble. This is not something you dip your toe into. This is something you go all out into. You create an expertise, a specialization in consult physiatry. We revamped our template to make sure that the template contained information that was relevant and important and directive to our acute care partners. And obviously, we developed the tracking tools so we could have metrics. So when we developed our consult physiatrist sort of career path, we said there's 3 goals that we want our physiatrists to do. We want them to manage patients at the bedside. They're expert in managing pain and spasticity. They're the ones that are going to put in the prescriptions for the therapists and guide and communicate and talk and get feedback from the therapists. And our PM&R physicians have special knowledge and training in management of TBI and spinal cord, et cetera. We promoted the work that our PM&R physicians could do in the acute care setting. We said, we'll take the role of disposition planning. We'll work with your care managers and social workers and your medical directors, and we will determine with you whether patients should go home or to post-acute care. And if they're going to go home, we're going to make sure they follow up with our physiatrists in the outpatient clinic to make sure that functionally they continue to improve. And then we also said that our PM&R physicians need to work on programmatic development like the ICU mobilization programs. So we wrote this out for our physiatrists to know what they needed to do and for our acute care teams. We told our acute care teams, identify patients early. Consult us when the patient's still in the ER or in the post-op setting. Don't wait weeks until you think they're ready to come. Consult us early so we can be involved early. Put an electronic medical record consult order that helps us track the orders and the timeliness. Make sure our physiatrists are constantly checking their list to make sure if a new consults come in, they can go and see them right away. Make sure it's being completed. The note is done, completed with a directive, a clear directive within 16 hours. And if they're not going to go home, make sure that our admitting department is also aware that the patients need to come to RUSC and we need to start working on that process. Make sure that a chat is initiated between our inpatient physiatrists, our consult physiatrists, our admitting department, the acute care team, to make sure everyone's on the same page and make sure that our physiatrists are following up with patients on a regular basis. Again, this is a complex process. And when we thought about this process of transitioning patients from acute care to the inpatient rehab facility, we actually didn't know every single step. We didn't know everything that we were doing. And we really didn't know where the bottlenecks were or how things impacted on that whole process of sending a patient from the acute care setting to the RUSC setting. So we decided to map this out and provide a timeline. And some of this timeline is in parallel and some of it is in series. And I'm sure if you've not done this yourself, you can do it yourself to really understand your process. So there's transparency. So the acute care team know where the bottlenecks are. So the administrators know where to give resources to make sure that we're all on the same page, we're following the same culture, the same process. And this slide sort of gives you a heat map. Green is good, as in the time's coming down. Red is not so good, the time is going up. The goal is to have everything green. We're doing better sometimes and not so better at other times. There's often outliers. But we look at this on a daily, weekly, monthly basis and share this with all our partners to show how we're doing and to really understand how long is it taking from the time a patient is admitted to the hospital to put in that physiatry consult. How long is it taking to get that physiatry consult completed and signed? What's the discordance between the acute care team's medical clearance and our rehab physician's medical clearance? There's a disconnect sometimes. There's a misunderstanding in terms of what we can do and what we can't do and what's stability and what's not. And then there's the financial piece. And Medicare patients are pretty straightforward. Medicare is not a challenge in terms of admitting into the inpatient rehab facility as long as they meet the criteria. The authorization is routine. But for our private payers, our insurance companies, non-Medicare, it's a real issue and a real barrier. And financial authorization has been a real sticking point for us. And this prompted us to develop another program, which we've called RAPA, the Rehab Admission Pending Authorization. We took the step of admitting patients before they were authorized by the insurance companies. We were recognizing the patients waited at least hours. At the weekend, it could be Friday through till Monday, waiting for the insurance company to process, to run it by the medical director and to give approval. It could be a 3 or 4 day wait while the patient otherwise was medically ready and functionally appropriate to be admitted. So we said, all right, we'll take the bold step. We're going to develop a pilot, which we did in April of 24. We chose what we call the slam dunk patients, those patients who we knew it was obvious they've had a stroke, they're neurologically complex, they met medical and functional criteria. They had a strong discharge plan to home. They did not have authorization, but we admitted them. And we applied for authorization after they were admitted. And when we started doing this, every single insurance company threw their hands up in the air and said, "What are you doing? You don't have permission." But at the end of the day, after peer-to-peer discussions, every single case, every single insurance company, bar two, there were two that did not approve and consistently didn't approve. So we've excluded them from this program now. But every single insurance company, in an unspoken manner, there's no emails, there's no written word, there's no directive saying that this is what we're going to do. It's just understood. And it's a win-win-win. Win for the patient, win for the insurance company. They stop paying for the acute care. A win for the health system. We can backfill those patients. So it's a win-win-win-win-win. And we expanded that process to all of our campuses in Manhattan and our Brooklyn campus as well. We spoke with the acute care team so they understood what was going on. We made sure Rusk Outreach and Admission, our admitting department, knew what was going on and this was going to be a rapid patient. We made sure that Revenue Cycle initiated the authorization once the patient was admitted and worked with the insurance company to make sure that we got paid. And we made sure we communicated to the patient and the family to make sure that they understood as well that if their stay was denied, they would not be financially responsible. We took that risk. We knew that if we didn't get paid, it would be on NYU. It would not be on the patient. It wouldn't be on the family. They would get their normal standard care, their length of stay, the testing that they needed, the consults that they needed. Everything would remain the same. So let's look at some of the data and the outcome. This was the pilot that had started in April. As of May, I tried to get updated data. I couldn't get it in time for this talk. I apologize. But as of the end of May, we had close to 160 patients who had been admitted, 56 to our Brooklyn campus and 103 to Manhattan. 82% of all patients who were admitted under the RAPA program were discharged home. There were 10 admitted back to the acute care setting and 17 that went to skilled nursing facility. Every single one of those skilled nursing facility stays was approved by the insurance company. 88% of all RAPA patients got insurance approval and 63% are paid in full so far. It's a rolling payment. They don't pay all in one go, but our success rate in getting 100% is increasing and increasing. So overall, this has been a very, very successful program. And this as well is also very telling. A third of patients are admitted at the weekend or on a Friday, saving over 2 days in terms of length of stay. That means those beds can be backfilled from the ER and from the community. So in summary, we saved 2 days length of stay for patients on average, for patients coming into Rusk without prior authorization. 158 days saved a year as it translates out as we annualize it. The opportunity to admit 31 additional patients and a $500,000 margin in terms of capacity that's freed up from those 31 additional medicine discharges. So it's been a very, very successful program, moving patients through quickly, and it's been effective in terms of time saving and cost as well. So let's look at some of the outcomes from some of the initiatives that I've discussed, the ICU, understanding our process, our consult service, and our RAPA, Rehab Admission Pending Authorization. So as I told you before, we were an inefficient system, an ODE length of stay that was over 1, which is sort of the threshold, but closer to 1.2, and that fiscal year 21.42. But putting all of this into play and changing the culture and having conversations, now in the last full fiscal year, which was fiscal year 24, our observed to expected length of stay of patients coming into Rusk is down at 0.89, indicative of a highly efficient system. Everything that we've done has made a difference in moving patients through sooner. What about our physician productivity? I told you we were about 3,500 consults. We moved up to about 4,000 consults. It's still my goal to grow that consult volume higher. We were at 54% signed within 16 hours, up to 71% in the last full fiscal year. Our observed to expected length of stay went from 1.42 down to 0.89, a direct correlation not just with a consult service and an efficient consult service, but with changing the culture and improving the communication and understanding the process. Everything we've done has made a significant difference in terms of the efficiency of moving patients from the acute care setting into RUSC. So what about some other key healthcare metrics? And I'm not going to go into too much details on most of this, but this is what we look at when it comes to our inpatient setting, our occupancy, again, our length of stay. If patients are meeting the 60% rule, our hospital-acquired complications, our financials, and our readmission rate. And we've had issues with our readmission rate, which I will come back to in a moment. But all of this data is summarized on a monthly scorecard. And this monthly scorecard is transparent to the point where it gets sent to our site chiefs, physician chiefs, the nurses, the nursing leadership, the therapy leadership, our administrators within the department, and the executive leadership. They get this on a monthly basis. We're fully transparent with everything that's going on, from our financials to our inpatient service, to our outpatient services, and our patient experience. And we are held accountable. I'm accountable to my chair, and my site chiefs are accountable to me, et cetera, et cetera. We make sure that we are all answering and understanding what's happening, what the trends are, making sure we meet our goals. So what about readmission rate? So this has been another challenge for us. And one of the initiatives that we recently embarked upon, actually in the last 5 years, is called transitional care management. And again, if you've not heard of this, this is something that you really should pay attention to, because it makes a difference, and I'm going to show you that in a moment. But readmissions are a significant issue in our health system. There's 3.8 million 30-day all-cause readmissions from a hospital. This was data from 2018. It's probably more than that now. It's approximately a 14% readmission rate, and annualized $52.4 billion on 30-day readmissions. Most of which, if not, if I'm bold, all of which are preventable. Transitional care management is a program that's really applicable only to Medicare patients, but we put it in place for all of our patients. Applicable only because Medicare is the only insurance that reimburses for a transitional care management program. But it's worth implementing because of the impact that it has on readmission reduction. It covers from the day of discharge until 30 days post-discharge. That means that the physiatrist or the LIP is responsible for the patient's care and care coordination during that time period. It is a physician-supervised and managed program, a care coordination program, but there is enhanced billing for it, and I'll go over that in a moment. And in the acute care setting, for patients who've been discharged from medical settings to home, there is evidence-based that this reduces readmissions. We don't have the same data, or not until now, for rehab facilities, but I think you're going to see that that is the case with the data that I'm going to show you. The requirements include an interactive contact with a clinician within 48 hours of discharge. We have a discharge nurse that calls our patients to check and make sure they're doing okay at home within 48 hours. There needs to be a face-to-face encounter with an LIP. It can be a nurse practitioner, that's what we're using now, or a physician, a physiatrist, within 7 or 14 days. Must be within the 2 weeks, a face-to-face encounter. It can be a video visit or in person, and we found video visits work better because patients are still acclimatizing to being at home. And that, as I said, follow-up period, that period of responsibility is for 30 days. You do not drop the bill for a TCM encounter until 30 days have passed, and the patient cannot be readmitted. If they're readmitted in that time period, you cannot bill for a TCM visit. You can bill for an E&M visit, but not a TCM visit. So this is some of our data, and I've just given you the last 3 full years and fiscal year to date for 25. And you can see that in the gray bar, over time, we've increased the number of patients who have a TCM visit. We're just over 50% at this time, but we want to do better than that. And what about patients who got TCM visit or part of the TCM program and their readmission rates? You can see a significant difference between those patients who had a TCM or part of the TCM program and those that weren't. In terms of readmission rates, the percentage is starkly different in terms of the percentage, the absolute numbers and the percentages of patients who required readmission within 30 days. So fiscal year 25, 3.71% of patients who had a TCM visit were readmitted, as opposed to 6.3 who did not have the TCM visit. So again, TCM, transitional care management, that enhanced management and oversight for the 30 days following admission significantly reduces readmissions amongst rehab patients who are discharged from an inpatient rehab facility. And this is the billing. It's an enhanced reimbursement rate. If patients are seen within 7 days, close to $300, and 14 days, just over the $200. But if you do the math, if your physicians or clinicians are seeing 10 patients a month for 12 months, that's an added income of between $24,000 and $33,000 for the clinician who's doing those visits. So fiscally, it makes a difference to your income and your balance, but also with regards to readmission reduction, which is the most important thing in terms of its reduction. So finally, we can't have this great data and these great initiatives if we don't know how to communicate and tell people what we do. You've seen this before, I am sure, and I'm going to read it out just so that these words resonate in your ears. PM&R physicians are the essential medical experts in value-based evaluation, diagnosis, and management of neuromusculoskeletal and disabling conditions. And we are indispensable leaders in directing rehabilitation and recovery, vital to optimizing outcomes and function early and throughout the continuum of patient care. These are direct quotes from PM&R Bold, but I am sure they resonate and ring true for you as well. And we understand, and this is what we need to communicate, that PM&R physicians see the whole patient and the family and the caregivers. We see the whole clinical picture, the continuum of care. We see, or we integrate into the team, and we also help all team members integrate as well. We impact positively key metrics: observed to expected length of stay, hospital-acquired complication reduction, reduction in 30-day readmissions. We impact positively the financials. We impact positively the patient-reported outcomes, including patient satisfaction. And that, without a doubt, leads to improved reputational scores and improving brand loyalty. So we got to make sure that we're talking with our departmental chairs and administrators. In all the departments that we work with, we must make sure we're working with our research and education leaders to make sure that we're got the right research projects and quality improvement projects in place, and that we're educating all of our teams. And we must make sure that we're reaching out across the continuum of care as well to our SNFs, LTACs, the insurance companies, and the legislators. Talk with the clinical leads at your site. Talk with the research leads in other departments, the administrative leads. Understand what their sticking points are, what their needs are. Show them that we can be part of their solution. Remember, there are tools as well for our healthcare partners. This is a product of the FAAPMR SBE committee, Specialty Brand Expansion Committee. And this is a sort of a leave behind. If you're talking with executive leadership or administrators or department chairs, give them this form. It tells them what you do. It tells them how you can help improve their quality of care and their metrics and throughput. So as I wrap up, remember, ICU early mobilization, again, you were the leaders. You showed the country and you've helped us. Thank you. It makes such a difference. Make sure that that program remains vibrant. Make sure you're enhancing your PM&R consult service. It makes a difference in terms of throughput. Make sure your PM&R physicians are consulted early, they're engaged throughout, that they continue to follow up with patients on a regular basis, that they're communicating with the inpatient doctors on your rehab floors, with the therapists, guiding everything, managing all those things that they know how to do from their specialized training. Make sure you understand your acute care to IRF throughput process. Again, we did it, but we didn't fully understand it. Create timestamps, set yourself goals and standards. Understand where the sticking points are. Understand if that's a process issue, a resource issue, a culture issue. Work with your executive leadership for those resources. Work with your acute care teams for that culture. But make sure you understand the process. When you dissect it, it's an aha moment. Consider RAPA. It's worked for us. We're not the only department that's done this. There's another department in New York that's done this as well. but the data speaks for itself. The insurance companies, whilst they may initially throw their arms up, they realize and recognize that this works for their patients, this works for their finances, and this works for the executive leadership. And by the way, we didn't do this without getting the full approval of our executive leadership at the highest level in our hospital. And transitional care management, it makes a difference in readmission reduction. And I think it's a challenge that we all face. We're seeing much more complex patients. We're sending them home to complex environments. Transitional care management makes a difference in terms of readmission reduction. So I hope I've stimulated your minds. I hope you've been thinking about how we demonstrate value. I hope you've been anticipating opportunities, what you can do with Johns Hopkins. I'm sure you've been considering administrative strategies, and that if not now, in the near future, you're prepared to discuss this internally in your department, as well as with your non-PM&R chairs and leaders and your executive leadership, as well as other departments outside of Johns Hopkins. And with that, I will stop. That's my email. If anyone wants to be in touch with me or ask any questions, I'm happy to share. We are very transparent here at Rusk. We'll share with you. We do believe that sharing this kind of information and these strategies and initiatives, our wins and our losses, is really key for us as an industry to continue to enhance. And with that, I'll thank you.
I'm wondering if I can jump in.
Hi, Preeti.
Hi, Jonathan. Thank you for this amazing talk. Really enjoyed every minute of it. I think it's fantastic what you've done. I'm wondering if you could elaborate on a couple of things. Number one, the O to E ratio seems to be really important, but could it be sort of used in a negative way? For example, we know that with Medicare Advantage, people, insurance may refuse to pay, or it may be difficult to, are there mal-incentives, in other words, for being too efficient? So I think you get the gist.
Yeah, I get the gist. And the answer to that question is, as of this time, I don't know. I'm not sure if anyone knows, and I'll say that because, again, and not that I have blind faith in our executive leadership, but your executive leadership, our executive leadership, these are people with great minds, and they understand the healthcare industry. And I have not heard of any insurance companies' plan or action to cut reimbursements based on the fact that, hey, you're getting your patients out quicker. No, I think on the contrary, I think they're supportive of this, because we know the hospital is sort of a bad place to be. A hospital is where complications happen. And I think what you see in the reduction in hospital-acquired complications goes hand in hand with a reduction in length of stay. The shorter period of time people are in the hospital, the less time there is for complications to happen. And it raises the awareness and the acuteness in terms of the observation of patients and the strategies to limit catheter-associated infections and pressure ulcers and falls. So because we want to get the patient out quicker. So I hope I'm answering your question. I've not heard of any malintent. I've not heard of any adjustment in reimbursements or payments. I've not heard of anything negative coming from insurance companies, but I may not be the first one to hear. Above my level, at a chair's level, or maybe higher still at an executive leadership level, they may hear, but they are still full steam ahead in terms of bringing down observed expected length of stay.
Yeah, no, I don't mean the insurance companies paying less, and I think they would be very happy that the length of stay is lower. But I just was wondering, and clearly, like you said, that keeping the patient in the hospital is not a good thing. But some patients may need it, and I'm just wondering, is there could there be too much of a push for that?
So again, that's a good question. And again, we look to like readmission rates. If people were being sent out of the hospital too soon, are we going to see a rise in readmission rates because they were not stable? On the contrary, the readmission rates have come down.
Right.
But I hear you, and I also have a degree of discomfort with moving people through quicker. It does take a lot of collaboration with community services as well, with home care agencies. And that's also, again, the role I mentioned of our consult physician. If a patient's going right home rather than going into post-acute care, we make sure that an outpatient visit is set up within 2 weeks with our outpatient physicians. Well, that's our goal. I don't have the data for you on that yet, because we know there are challenges in getting patients from the hospital setting, even the rehab setting, into an outpatient visit with a PM&R doc within 2 weeks. But we do it for every single patient that leaves Rusk. They get the TCM visit from our nurse practitioner, and then they get a follow-up visit with one of our physicians within 2 weeks of discharge. That's been a major push of ours to make sure that they stay healthy in the community and we reduce that readmission rate.
That's fantastic. Thank you.
It's great to see you, Preeti.
Hello, this is Ning. Thanks for your great talk. I do have a question, based on your inpatient rehab beds, do you have any struggling to fill the beds from internal referrals? What percentage you receive from your NYU acute care services, or you're struggling with the long waiting list to get a bed for ACIR?
Yeah, that's a great question. And so it does fluctuate. Sometimes we fill completely from our inpatient, from NYU inpatient sites. As I said, we have 3 sites. We have one on Long Island, we have one in Brooklyn in terms of acute care setting, and one in Manhattan. And sometimes we're full completely from our internal referrals. One of our units, our medically complex and transplant unit, fills only from internal patients, because we have such a vibrant transplant program now and medically complex program that we don't take patients from outside. For our Brooklyn site, the bed number went down from 30 to 25. And so in the last 6 months, we've been about anywhere from 10 to 20% filling from external sites. And then for our second site in Manhattan, it ranges anywhere from 10 to 30% of patients coming in from outside sites. So I think in the other part of the question was, is there, do you sometimes have no beds and therefore you're delaying patients moving into your rehab facility because there's no beds? No. So I'm trying to think. I think I'm comfortable in saying we have never had a situation where we did not have a bed for a patient. We have never had a situation where we haven't had that. So we run around an occupancy anywhere from 88 to 92%, which means that there's always a bed somewhere. And our target occupancy rate is 88%. We recognize that sometimes, because we have some private rooms, but most of them are dual occupancy. Sometimes there's gender issues. Sometimes a room or a bed is closed because of some construction or a leak. Sometimes there's infection prevention issues. So we don't have a 100% occupancy goal. But there's never a time when we don't have a bed somewhere in our system out of those 95 beds to admit someone.
Thank you. Thank you for your insights.
You're welcome.
That's very helpful.
I do recognize the time. I'm sorry if I did not leave enough time for questions, and I'm sure you have other things that you have to get onto. I know I do as well. I'm already getting a knock at my door that I have patients in my clinic. But as I said, I'm honored to be asked to come and talk with you. I hope this has been helpful, provocative. You can look internally. You can look. We can partner. We can learn from you. Would love ongoing dialogue with you. Marlies and I see each other on a regular basis through the Board of Governors with FAAPMR, and we We often discuss things like this, but I do want to thank you for inviting me, and happy if anyone wants to reach out.
Thank you again, Dr. Whiteson, for an excellent talk, and everybody have a wonderful day.
Thank you so much.